Hey colleagues, if you are a mental health professional but feel like you don't have an understanding of the basic medicines that are used to treat common mental illnesses, then listen up, because in this series we're diving deep into psychopharmacology for therapists. Welcome to Psychopharmacology for Therapists. In this series, we're going to take on common mental illnesses and the common medications that are prescribed to treat these mental illnesses from the perspective of therapists. We're not going to go into the nitty-gritty of every single detail about molecules and chemistry because therapists don't need to know that stuff. Just an overview of the basics, with me, a real-life therapist, also giving commentary on how I've seen these medicines used in the field and in my own practice. Now, you might be thinking, Jim, why do I need to know anything about medicines? I'm a therapist. I do talk therapy. I'm not prescribing medicines. But it is really important that you and I have a basic understanding of this very important tool for mental health. First off, medicine is an important supplement to therapy. Now, while we all generally know that therapy is one of the most effective interventions a patient can ever receive, we also know that their primary intervention is usually going to be some kind of medicine that they got from their primary doctor. And that's important to keep in mind because most of your patients are going to be on medicine already by the time they get to you. So you should have a basic understanding of what those medicines do and what they're for. Another important reason is that whenever your patient tells you about medicines they've taken in the past, those are important clues to symptoms and experiences they've had in the past. If they casually mention a mood stabilizer or an antipsychotic, it's important that you know what those medicines did when they took them because that teaches you valuable lessons about your patient's history. Lastly, some of the major roles that we as therapists can provide when it comes to medicine is education, referral, and monitoring. And that's an important function that we have as therapists, and that can only be done if we have a basic understanding of medicine itself. So let's talk about these three big functions that we as therapists should be doing when it comes to our relationship to medicine and the patient's relationship to medicine with us. Number one, we're here to educate. You need to have a firm understanding of psychiatric medication because you need to be able to give your patient accurate information about these medicines. That doesn't mean that you're the one offering them the medicines or telling them what to take, but you may be that first person in their relationship with medication that can teach them about what medicines are effective, what medicines are common, and demystifying some of what medicines actually do. Another important function you have as a therapist is being the one to refer them, to tell the patient, I think you would benefit from medicine, and I want you to go see your primary doctor or a psychiatrist in order to get those medicines. And giving your patient the information of here's how to ask for that, here's how to talk about that. You can tell the doctor, my therapist suggested I talk to you about these medicines. So that referral source and what we call a warm handoff is an important function of what we do as therapists. And lastly, another important function we have is to monitor. That means that we're keeping track of patients that are on medicines. We're noticing things like symptoms, improvement, difficulties, side effects, and we're helping them maintain compliance with those medicines, coaching them, normalizing some of their experiences, and also knowing what to look for if some of those experiences are not good. It's important to keep in mind that those three primary functions are actually almost the only functions that therapists should have when it comes to our relationship with medicine. You, as a therapist, are not a prescriber. It is way outside of your scope. You can inform people, you can make recommendations that they consult with another professional, and you can assist as part of the medical team monitoring those patients. But you do never prescribe medications. You never suggest medications and tell them, I want you on this specific medicine. I've read about it. It's really good. You should take it. No, you can send them to a physician or a psychiatrist. You can educate them about options and then encourage them to talk about that with the prescriber. So we do not prescribe medications. We also do not direct the use of medications. We don't tell the patient how to take their medicines, when to take their medicines, or come up with creative suggestions like, why don't you take a double dose, or why don't you cut that one in half? That is outside of our scope. We provide support, education, referral, consultation, and monitoring. We do not tell them how to take their meds or specifically which meds to take. We also don't tell them not to take their meds. If they've been prescribed medicines, we refer them back to their physician, back to their prescriber, and say, why don't you consult with them about what you're going through? Let me help you language that so that you know what to say to that doctor and to report your truth. But we do not tell them, hey, I want you to stop taking that sertraline and start taking this other thing, or start taking these supplements, or cut that one in half. This is well beyond the scope of what we do. And so we never do that. We only educate, refer, and monitor. Speaking of things we shouldn't do, another important one is casting doubt on the prescriber. Yes, there's going to be times when we really think a doctor is making the wrong decisions. We're going to think that that psychiatrist or that primary has a fundamentally misunderstood view of the patient and what their symptoms are. But we have to be very, very careful, because if we start casting aspersions on the prescriber, casting doubt on their medical choices, we're operating outside of our scope because we are not part of that prescribing chain and we should not be offering some kind of second opinion on that. We can refer, again, one of our primary functions, to another doctor or ask the patient to consider another clinician in the same psychiatry clinic and get a second opinion. We can offer information and write some kind of case summary and get permission to send that to the medical clinic to say, hey, here are the symptoms that I've charted. Here's what I've noticed. It's important that you, doctor, have all that information so that you can make the best, most informed decision possible. But we do not cast doubt. We do not tell the patient, your doctor's bad, they're making bad choices, or cast doubt on the medicines that are being prescribed. And a good reason for that is the same reason that the airline industry never advertises safety as one of their key ingredients for their brand. You don't see Delta saying, we are a safer airline than Frontier. You don't see Frontier saying, we are a safer airline than Spirit. And the reason for that is because the entire industry knows that it benefits nobody for any person to have any fear for the safety of airlines. All airlines would suffer equally and do suffer equally anytime there is a crash. In the same way, mental health care needs to have that same mindset. It's hard to address mental health care needs. It's hard for patients to seek medication. It's hard for them to get help. When we cast doubt and we criticize other prescribers or other providers, what we're doing is taking away the credibility and safety of the entire mental health field. That doesn't mean that we have to support every decision everybody makes. Certainly we can lobby for correction, we can do this professionally, but it's very important that we as therapists know that our role is not here to second guess the prescriber or criticize those medical choices. Yet another thing that therapists should not do is try to play armchair pharmacist and say, okay, I won't try to prescribe any medicines because obviously no pharmacy would fill them, but I will tell you that you should take some kind of natural supplement, or you should go take some kind of special substance, or eat this kind of diet and increase or decrease this or that. Look, again, those are things outside of our scope. There are other providers who are nutritionists and dietitians and physicians who should be making choices about metabolics and chemistry and nutrition in these patients. When we start telling them which over-the-counter medicines to take or which supplements to take or how to eat or live differently, we're stepping well beyond what we're here to do as functional mental health providers. We can refer them to other professionals. We can educate them and insist that they think about those things and make their own choices. But we have to remember it is outside of our scope. We are here to educate, refer, and monitor. Lastly, another important no-no is to remember, and I can't believe I have to actually tell people this, you cannot suggest or give your patient narcotics. Even if you feel like psilocybin, mushrooms, marijuana, or any other exciting narcotic is on the cutting edge of science and you're really, really passionate about that new exploration, it is a federal crime and so far beyond your scope of practice to ever provide these people with any kind of medicine, supplement, and especially a narcotic. That is drug trafficking. You will not get a pass just because you were trying your best to help people or because you can print some PDF that says that there's been some encouraging research. Medicine is prescribed by a physician and dispensed by a pharmacy, not bought on the black market or the shady side of the internet and brought to the patient in your office, no matter how you try to envelope that inside of you're just making your own choices or I'm just connecting you to outsiders. I have nothing to do with it. You're facilitating drug trade. It is a federal crime, and it is not what we are here to do. We as therapists only educate, refer, and monitor. So now that we've talked about what you should and shouldn't do with all this information, let's have a roadmap of what we're going to talk about in this presentation. The four big areas of medication that I think every therapist should be somewhat familiar with are as follows: antidepressants, anxiolytics, which are basically what we use to treat anxiety, bipolar medicines, sometimes called mood stabilizers, and antipsychotics. Now, these medicines can treat different things. It's not like only antidepressants can be used to treat depression or only antipsychotics can be used to treat delusions or psychotic symptoms. These things have a lot of crossover, but generally speaking, they do fall into those four buckets and they are used to treat those four particular mental illness packages. In this series, we're covering the most common forms of medicine and mental health to help therapists feel confident and familiar with their work. I hope you'll use these videos as a resource for yourself or your colleagues, and I look forward to sharing more with you in the future.